I got Pyramid, Magellan, bunch of different agencies here. Awesome. And then our presenter for today is Anita Kelly. So I will read a short bio about Anita and then I will go ahead and turn it over to you. So, Anita Kelly is a Pennsylvania licensed professional counselor and certified advanced alcohol and drug counselor. She has been working with individuals with substance use disorders and co occurring mental health disorders for over 30 years. She has worked in all levels of care throughout her career, in addition to maintaining a private practice. Anita also taught courses on psychology and substance use at higher education institutions. She is currently the clinical contract advisor for Magellan of PA. She served on the board of Pride of the Lehigh Valley, FACT, and the Health Advisory Board of Bradburn Sullivan LGBT Center. She was the LGBT coordinator at Muhlenberg College for 10 years, in addition to being the director of counseling services at Muhlenberg for 18 years prior to coming to Magellan. Anita also has her own podcast called Les Talk About Books, Baby, where she interviews LGBTQ authors. She received her certificate from the University of South Florida in DE&I and the workplace, and she's also a trainer and speaker on topics related to addiction, recovery, harm reduction, and treatment interventions.
Well, thank you so much, Arlene, and welcome everyone, and thanks for being here. Um, I hope everyone can see the screen. It is the first slide of the slide deck. And what I'm going to do is actually I'm going to go off of audio because oftentimes when I do presentations and share my screen may freeze if I'm also on audio. Gives me more bandwidth, or on video, gives me more bandwidth when I am not on video. But during the presentation, feel free to raise your hand, put something in chat if you have a question. Arlene, again, will be monitoring that and will be letting me know. So hope everyone sits back and enjoys the presentation today. All right, so we are going to be talking about the 3.1 level of care, which you know is the halfway house level of care. And our objectives are for today are to learn about the 3.1 admission criteria, to identify some criteria nuances, and to use that criteria to make informed decisions about a member's care. Our agenda for today is to review the ASAM dimensions. We will look at the 3.1 admission criteria. We will review some questions that are specific to each dimension. We're going to look at the 3.1 level of care services. Just so everyone understands what a halfway house can provide and what they cannot provide. And then finally, I have two case studies that we can take a look at. And of course, there's should be some time for questions at the end. But again, feel free to jump in at any time. So before we get started, I wanted to remind everyone of the guiding principles of the ASAM criteria. Oftentimes when I go to ASAM trainings, people don't look at these and remind folks that these are there, and they really are something that helps us do the work that we do, right? It helps us be aligned with ASAM. And as you know, probably most of you have gone through some type of ASAM alignment review, if not with Magellan, with another BIMCO provider. So these are good to keep in mind as you move along and do the work that you do. And in addition, I wanted to share with you these guiding principles, which I think are really important. In that ASAM asks us to look at the least intensive and the least restrictive level of care, We want to make sure our clients are safe, they're getting what they need, but we don't want to put them in a higher level of care than absolutely necessary. And folks can move from one level of care to another, right? This is variable. The length of stay is variable. And those are things that really guide us. I think those are the backbones sometimes of what ASAM is about. Um, Also, we want to ensure that we are providing individualized treatment for all of our clients, right? And if you look on page 420 of the ASAM uh, edition 3 text, they talk about just this, how, treatment should be person-centered. And that's not always easy to do when you work in a residential program, for instance. You have to be creative, I think, and that presents some challenges. But one of the things we do not want is a program-driven model of care, right? With a program-driven length of stay. All right. So these are the levels of care that we have in Pennsylvania. Um, Starting with 1.0, which is outpatient, 2.1 is IOP, 2.5 is partial. We have 3.1, which we're going to be talking about today, which is the halfway house. And then the next level is 3.5, which is the residential. We also have 3.5E, which is 3.5 enhanced, which is the co-occurring program. And that is a facility that has both their mental health and their drug and alcohol license. We also have a 3.7 level of care and a 4.0. And then, of course, in withdrawal management, we have 3.7 and 4.0. And you'll notice that we have removed 3.3 from this diagram because with the new fourth edition of ASAM, even though in Pennsylvania, we do not subscribe to that as of yet, 3.3 has been removed from the continuum of care. All right. Any questions so far? Um, I just would also like to say that most of the providers within the Magellan network are contracted across all of our counties. As you know, we are in Lehigh, Northampton, Bucks, Montgomery, and Cambria counties. And usually, if we are, for instance, contracted with White Deer Run of Allenwood, we are contracted for all of our counties. And if we're not, we have been working to amend those contracts and include all of our counties. So I do want to focus on that continuum of care because I mentioned that before, that you do not need to enter at a residential level of care. You can enter at a 3.1 level of care if that is what is necessary and if that is what really works for a particular client. It's unusual, yes, but there are clients that that is really most appropriate for. I think one of the things that I would like to point out is that oftentimes there's this knee-jerk reaction that when someone relapses, we need to step them up. And that is not the case. And actually, the new ASAM Edition 4 addresses that. We've been saying that for a while, that, you just need to work with the individual rather than, ask them to leave, do an administrative discharge, and move them to another level of care. So that is addressed in the new ASAM book, which I am really happy to see. So these are the 6 dimensions of ASAM criteria, right? Everyone should be familiar with all of these. And if you're not, we're going to go through each dimension. So hopefully by the end of this session, you will be familiar. Um, and some of you may be familiar with the fourth edition that I've mentioned, and the fourth edition is out, and changes were made to these 6 dimensions. But I also want to say in Pennsylvania, we will continue to operate using the third edition. Third edition trainings by the Train for Change program will still be available for the state of Pennsylvania. There are a couple of other states in the union that are continuing to use the third edition as well. So no worries there. Trainings will be available for us. So these are the 6 dimensions as they apply to the 3.1 level of care or the halfway house level of care. And we are going to dive into these. But before we do, does anyone have any questions, comments, statements?
No questions in the chat yet, Anita.
Okay, thank you. All right, so let's look at dimension 1 of 3.1. And I apologize because a lot of this is just going to be dry. It's just reading, these facts, but we're going to be applying them, which should get a little more juicier as we move on. But dimension 1 says that the patient has no signs or symptoms of withdrawal, or his or her withdrawal needs can be safely managed in a level 1 setting, a level 3.1 setting, right? So what we want to ask ourselves is, what is the current risk that's associated with this patient's level of intoxication? Um, what kind of withdrawal management service do they need, or do they need any at all? What are their withdrawal risk right now? What are their symptoms of withdrawal? Are they experiencing seizures? Do they have a history of seizures, a recent history of seizures? And we want to look at the CWA and the COWS scale. We also, when we're doing an assessment, some of you may know that our care managers will ask for vital signs, right? We want to make sure that someone is safe and able to go into a level of care that does not require medical attention, if that's what you're asking for, right? So what this basically is saying is that someone who enters a halfway house really should not be experiencing severe withdrawal symptoms. If they do require medical attention, we'll get into that. That is actually the dimension 2. But they may be experiencing protracted withdrawal symptoms. And we would expect that, as does ASAM, that a halfway house has contracts with a local physician, um, medical center, who will address those medical needs when necessary. So moving on to dimension 2, dimension 1 was kind of straightforward. Dimension 2 says that the patient's status in dimension 2 is characterized by one of the following. So biomedical problems, if any, are stable. They do not require medical or nurse monitoring. Or they have a current biomedical condition that is not severe enough to warrant inpatient treatment, but could be sufficient enough to distract from treatment or recovery efforts, right? So this problem may require medical monitoring. So I'm going to ask you all, what do you think would be like a medical problem that might fall into either of these categories? You can either put it in chat, unmute yourself. Anyone? All right. Well, I would think that possibly. Oh, go ahead.
Yep. Hep C.
Anita, we have a couple responses coming in.
Oh, good.
Diabetes, MAT, infection from xylazine, chronic back pain, Hep C, HIV, don't know if I said that already, asthma, hypertension, cancer.
You guys are good. Yeah. I would say that most of those, except xylazine, I'm not sure. Xylazine may require more medical attention than a halfway house is able to provide. But let's take someone said diabetes, right? So if someone has diabetes, and they are controlled on medication, that seems like it would be a good fit, right? But what if they're not controlled? What if their blood sugars are up and down and they're having all kinds of medical problems because of an uncontrolled condition? Um, I don't think that a halfway house would be a good fit for them, just because that may be more than the halfway house can contend with. It would require some pretty constant medical attention, right? Now, some halfway houses could, um, but so you would have to really be familiar with what services each program can and cannot provide. Um, Hep C is another great example. They can go out into, there are a lot of community clinics around who would treat that. A lot of them might be near the halfway house. So that is another great example. So some of the questions that we want to ask then are, um, what are the current physical illnesses that may be a risk for treatment complications, right? And if someone, let's go back to the uncontrolled diabetes, someone may not really be able to focus and maintain employment if their diabetes is not under control. So that halfway house may not be a good fit just yet. Maybe they have chronic conditions that uh, need to be stabilized before they go to a halfway house. You need to be aware of any communicable diseases. Like, are there any that could impact other patients or the staff at the halfway house? And we went through this, right? We all 4 years ago went through the pandemic, which just seems surreal. And that had a major impact on where we sent folks and how they were treated. And we also need to look at our special populations, like a pregnant person, right? Um, what is the pregnancy history, especially if they're an opioid user? Um, you know, can there be complications from that pregnancy? You know, can they be treated with all their needs be treated, I should say, at this level of care um, or at this particular halfway house? And for this special population, we do know that we do have some halfway houses that cater to this special population. So that may be a more appropriate referral than your typical halfway house. All right. Any questions about dimensions 1 and 2 before we move on?
A couple, Anita. So, question was asked about dimension one. What about pause symptoms?
Yes, you have to consider pause symptoms, absolutely. Um, and understand whether, a halfway house can work with that individual or not.
All right, thank you. Two more. Or this might just be a statement. Someone mentioned they have a client that has found out he has CA within the last 3 months. Um, Halfway house may not be the best option.
It might not be, depending on her medical needs. Um, you know, she may need more attention than they can provide. Yeah,
Okay,
that's sad. Sorry to hear that.
right. Now for HIV. If HIV is stabilized, would a halfway house be a good fit?
I don't see why not. Um, that's a good question. I think that if they're stable, they're on medication, and there's a doctor nearby to provide medication, um, and do regular checkups with the individual, especially if they're, um, newly diagnosed and on meds, then it could be an appropriate referral.
And then along the lines of HIV, several of our attendees in the chat mentioned HIV for Dimension 2. And a question was asked if this is something that we are able to write on the ASAM.
So HIV is covered under another regulation in Pennsylvania. I forget the number. I used to know, can't remember right now. But you need a specific release for HIV information. Now you can ask the client to sign that for Magellan, so that you could share that information with us, and we can work with you on getting the appropriate care for that individual. We do have an integrated care team who works with physical health MCOs, and they're part of our team, so they know what's going on in the behavioral health world with that individual. So, having a release sign is a great way to coordinate care.
Anita, I think it's Act 148.
You are so right. I was going to say that, and I was like, ah, but
You
that
got
is
it.
it. Yep. Thank you, Arlene. It's Act 148 that does have a special release.
And then another question, how do I get the release for HIV info? Is there a gene? I don't know if I'm maybe asking that correctly. I'm not sure if the person would like to ask that. Oh, a generic form.
Oh, for 148, most providers will have one. You can make, your organization can make one. Um, Probably if you go online and just Google a release, it will give you a generic form that you can, use, put your company's header on it, and use that. Um, or if anyone on this call who works for another provider, that your provider has one and you want to share it, you are welcome to do that. I know that all the organizations that I used to work with, we used to have our own Act 148 release.
Awesome. I
Any other?
think that are, oh, sorry, I was gonna say, I think that's all of our questions for now.
Okay, awesome. Great. Well, thank you all. Great questions. So we're going to move on to Dimension 3. So Dimension 3, um, the individual must meet A, and they must meet one of B, C, D, or E. Not all of them, just A and one of the others, right? So A is that the patient's mental status, including their emotional stability and cognitive functioning, is assessed as sufficiently stable to allow the patient to participate in therapeutic interventions provided at this level of care and to benefit from treatment, right? That's essential. They have to benefit from treatment. So can you think of a client who might not fit into this criteria? I think we've all worked with someone um, who would not benefit from treatment.
In the chat, I have maybe somebody with the TBI.
Great answer. Yes, right. Someone with a TBI may not really comprehend, depending on the severity of their brain injury, may not comprehend what's happening, may not comprehend a lot of the abstracts that we talk about in this field. Um, Although you can make adjustments and really be more concrete in what the materials that you present to someone with a brain injury.
Then a couple more answers, maybe active PTSD symptoms like flashback, nightmares, or active SI, auditory and visual hallucinations. If mental health symptoms are too prevalent, like paranoia or delusions, schizophrenia, another active hallucinating, cognitive disorders, autism with a question mark. Maybe someone that has autism.
Yeah. So those are all great answers. I think that one of the things that we often don't consider is what about someone who has a social phobia, um, and maybe they didn't realize the extent of their social phobia until they got into treatment and were drug free, right? And so right now you're thinking as a clinician, yeah, like a halfway house would be good for you. But would someone with social phobia be able to maneuver through the ins and outs of a halfway house, get a job, um, you know, and all of the other things that it entails? So that's something to consider, which we don't often do that. But the other one, someone who's actively psychotic. Halfway houses really aren't equipped to work with our co-occurring population, our actively co-occurring population. So great answers. All right, so let's look
What
at.
about, I'm sorry, what about someone that is like violent, constantly fighting and aggressive, like a very aggressive?
I'll tell you, Donna, I don't know of any halfway house in our system who would accept someone who's violent.
Absolutely. But sometimes you don't see it until they get there.
Right. Yeah, that's true. And so if you admit them into the halfway house, and they become violent, you really have to follow your policies and procedures. That's where those come in handy, you know.
Right,
Um,
right.
yeah, yeah.
Anita, while we're on this dimension, if you could weigh in on this question. Someone asks if schizophrenia is stable, would a halfway house be a good fit? Like if someone's not having like active hallucinations or symptoms associated with schizophrenia, would a halfway house be a good fit?
I think that each halfway house is different in whether they will accept someone with a mental health disorder or not. So I think that you would have to talk to the halfway house um, to gain that information. I would say that many of our halfway houses, they it puts them in an awkward situation, because they don't have a psychiatrist on staff. They don't have someone who can maybe help with that individual if they do become actively psychotic. So the only alternative is to maybe take them to the closest ED. So that's a tough one. It really is, but a good one. I would love it if all of our halfway houses had we're equipped to work with all of our co-occurring population because, I'm sure you see what I see, and that is that the majority of our SUD clients have a co-occurring disorder. All right. Are we good to move on?
Yep,
Anita,
we're
what
good.
about if somebody has had a recent suicide attempt? Recent, like maybe within the last 6 to 12 months.
Yeah, that's a great question, Hannah. I think that that is really dependent on the individual, um, where they are at in their journey. If they're in counseling, can they be set up with a mental health provider in the community where the halfway house is located? That's going to be so important. If they're on medication, can that be maintained? Those things are like vital. Do they have the supports at that particular halfway house for that individual? Does that help, Hannah? And
Thank you.
Good question. All right. So let's move on to the rest of dimension 3. So remember, they have to meet A, and the rest of these are an or. So their psychiatric condition is stable. So that means that their thought disorders, anxiety, guilt, depression, anything that may be related to substance use, or maybe a co-occurring disorder, is treated, and they are not a risk to themselves or others. So that is 1. And then there's C, where the individual's symptoms and functional limits, when considered in the context of their home environment, are severe enough that they are not likely to maintain stability, right? So an example of that could be that their home environment, maybe someone is being physically abused. So we recently had an adolescent who was being sexually abused at home. So we wanted to make sure that we had a good plan for that individual when leaving like their 3.5 level of care. There is no way they could go back home to that environment. And although halfway houses aren't available for someone who's 17 when they're 18, it might become available as an option for them. Then we have D. The patient demonstrates an inability to maintain stable behavior over a 24-hour period of care, or a period of time, or their co-occurring condition are being addressed concurrently through an appropriate psychiatric service. And this is what we were saying before. They may be appropriate if they're receiving care at the same time that they're in the halfway house. So any questions so far? All right, let's get into the questions that I have, what we want to look at here. So we want to make sure that if there are any psychiatric illnesses, that they're being addressed, they're receiving treatment for them, any chronic conditions that need stabilization, that they're receiving treatment for that, or that the halfway house is able to make sure they're receiving treatment. Oftentimes we see that once someone is drug free, are we seeing mental health symptoms that were maybe masked by substance use? This happens quite frequently, right? And, you know, is the halfway house, are they capable of working with that individual? Those are things that you want to know about particular halfway houses. So are behavioral symptoms severe enough to warrant specific mental health treatment? So if someone had a recent stay in an acute inpatient psych facility, is a referral to a halfway house an appropriate referral at this time? It may not be, right? It may be that mental health treatment might be more of what is needed at this time. Can someone manage their activities of daily living? If someone is, you know, depressed, even if they're being treated and on medication, and they can't get out of bed. I mean, we've seen this where someone will go to a halfway house, and their depression is the depressive symptoms increase for whatever reason. So that is not a good fit for them any longer, right? Can the person cope with whatever emotional, behavioral, or cognitive conditions that they present with? Halfway houses are communal living, and I would say that they're even more typical of communal living than a 3.5 level of care, where you have more structure. In a 3.1, you have less structure by counselors. So someone able to really live in that setting and, flourish in that setting. Those are some of the questions that you need to consider when considering a halfway house. All right, let's move on to dimension 4. So in dimension 4, we're looking at least one of these criteria, right? In dimension 4, we're really looking for the stage of change and their readiness to change. And as some of you might know, this dimension is changed in the 4th edition. They did not include readiness to change as a dimension in the new ASAM criteria, but we still use it here in Pennsylvania. So again, this is or. They don't have to meet all of these, just one. So the individual acknowledges the existence of their psychiatric condition or their substance use problem, right? So they're not in denial. They're able to see, how their life has been impacted, and they're able to work with that. They have a desire to make changes, right? They're motivated. The patient is assessed as appropriately placed in level 1 or 2. And is receiving level 3.1 concurrently. This is what I was talking about before, someone who may need level 1 co-occurring care, right? That's not provided in the halfway house. So we want to get them set up with a mental health provider or a co-occurring provider in their community. This is so important, or they're not going to flourish in the halfway house environment. Right. Then we go to C. They require 24-hour structured milieu to promote treatment progress and recovery. Other interventions have failed in the past. So this is why it's so important um, for all of our providers to ask our members to sign a release of information for Magellan, so that we may have information that you may not be privy to. Like, we have the history of mental health treatment and substance use treatment. And sometimes just because maybe a member forgot that they were somewhere being treated, they may be a poor historian, um, uh, whatever the reason, they may have not divulged that to you. So, these releases can be really, really important, especially when you're considering setting up some type of continuing care for clients. And then finally, D, the patient's perspective impairs his or her ability to make behavioral changes without the support of a structured environment, right? So they may need more of a structured environment to maybe maintain those changes, right? So again, it doesn't have to be all four, it just has to be one. And the questions that we want to look at are: how aware is the member of the relationship between their substance use, maybe their co-occurring disorder, um, and any behaviors that they have engaged in that have brought about negative consequences in their life, right? If there is legal involvement, what do they understand what role that has played in their substance use history? Um, do they understand what role it may continue to play, right? And how willing, or are they ready even, to make changes to their behavior? And sometimes folks will say yes, but their actions are telling you no, right? They're not, because they're still in contact with people who are continue to use substances, right? That's like a major red flag. That tells you that what they're saying is not congruent with what they're doing. And how much do they feel in control of their treatment? What is their locus of control? Um, you know, uh, is their use attributed to that locus of control? Um, you know, to so many, this could, just make life miserable. And we want to make sure that they have the coping mechanisms in hand when they enter that 3.1 level of care, right? Um, those coping mechanisms are going to help them continue to make those changes that they will need to succeed. So, any questions about dimensions 3 or 4, or comments?
I have a few, Anita.
Alrighty.
So when referring to appropriately placed at level 1 or 2, does this mean across dimensions or can it be for dimension 4 only? Like if a client is highly motivated and skilled but is waiting for mental health services, lacks stable housing, and is in the process of addressing legal challenges.
So I think I'm understanding that question to read: can someone be engaged in a level 1 or level 2 care while they're in a halfway house? Is that correct?
I
That was my question. I don't know if you can hear me.
Yes, I can.
Okay, good. No, what I mean there is, When it says appropriately placed at level 1 or 2, does that mean they should be in level 1 or 2 treatment, or that they are at level 1 or 2 for this dimension?
So that means that while they're in a halfway house, so halfway houses are only required to provide 5 hours of treatment per week, right? And for some folks, that is not enough to maintain their recovery, right? So we want to make sure that if someone needs psychiatric care, that that would be considered a level 1, right? Or co-occurring, that would be considered level 1, like outpatient, so that they are engaged in outpatient mental health care while they're in a 3.1. Does that make sense? Does that answer your question, Suzanne?
Yeah, yeah, I guess what I was more wondering was the meaning of appropriately placed at level 1, 2. Sorry, maybe I didn't phrase it right, but don't worry about it.
Okay, all right. Yeah, and that's taken directly from the ASAM book. They may explain a little bit more about that, like, you know, in the textbook itself, that might help clarify that.
All right. The next question is, earlier you mentioned getting clients connected with outside mental health services, but if a halfway house has contracted psych services with limited hours, would it be considered double dipping to also have clients receive outside mental health services?
Well, it depends. Yes, it would be a duplication if you were contracted with a psychiatrist, and the psychiatrist, usually in the state of Pennsylvania, our psychiatrists will only be medication prescribers. It would be unusual to have a psychiatrist who would also provide therapy. So if someone needs a mental health therapist who is not a prescriber, then that is not double dipping.
Thank you. And then the last question is, would a patient still be eligible for the 3.1 level of care even if they've had multiple attempts at 3.1?
That is a good question. And I would not generalize an answer, because I really believe that it depends on that individual, whatever else is going on with them. I think that may be one thing to consider, right? But again, we're going to look at all of these dimensions when making some kind of decision. So we don't base it just on one, piece of information. I know that was like a politician's answer, but
No, I
that
think that is great and everything's individualized. So,
definitely, yeah.
and I think those are all the questions I've received for now.
Okay, awesome. Let's just move on to dimension 5. So dimension 5 is characterized by one of the following, and we have A, B, C, and D again. So that the patient demonstrates limited coping skills to address relapse triggers, or they're in imminent danger of relapse for whatever reason. They need 24-hour structure, or they understand their addiction and or their mental health disorder, but are at risk of relapse because of some inability to address both, right? And that is where maybe, what we've been talking about, they need mental health care in addition to, a 3.1 level of care. Or there's C, where the patient needs staff support to maintain engagement. And by staff support to maintain engagement, for me, that means that the staff are teaching them life skills. They may be mentoring, you know, healthy recovery through having the client sit and watch them make phone calls, watch them make appointments. We have clients who don't even know how to get a prescription filled. They leave someplace, they're given a piece of paper, and they're like, "Yeah, what do we do with this?" So those are life skills that many of our members need to be taught, and actively, not just saying, "Hey, you know, you need a psychiatrist appointment, go make one." You know, that anybody could do that, right? That is not active care management. Active case management means that you're making those calls for our members. So then there's D, where the patient is at high risk of substance use, addictive behavior, or deteriorated mental functioning in the absence of close 24-hour structured support, right? And again, that goes back to structured support. So what would need to occur in a halfway house, right, is that staff are available, they're receiving counseling, they're receiving those services that they need, and they're not, you know, sleeping till noon, and they're not, you know, on a blackout for 2 or 4 weeks and just hanging out, right? That is not structure that someone needs. That's when people get into trouble. So some of the questions you want to ask at this for this dimension is, are they in imminent danger? Do they recognize or understand the coping skills that they've been taught? Do they have medications that they need assistance with? What are their coping skills with protracted withdrawal? Are they aware that they could even experience protracted withdrawal or cravings or impulses once they, you know, get out into the working world? Are they able to deal with peer pressure? Are they able to deal with stress, right? So these are the things that we need to consider for this dimension. And then our final dimension for a 3.1 level of care is characterized by A, and then either, again, B, C, D, E, or F. So A is that the member is able to cope for a limited period of time outside the 24-hour structure, right? So they can go to work, they can go to school if they need to, they can maybe go for a mental health appointment or a doctor's appointment, or go to a community meeting without, you know, having someone be attending to them, right? And again, this doesn't mean that they spend their first month adapting to the flow of the halfway house, right? ASAM doesn't recognize levels within halfway house programming. You know, when a client enters a halfway house, they are, you know, oriented to the expectations, and they should actually be kind of oriented before they even get there, by a phone call, like through a phone call with the 3.1 provider or the individual who's making the referral, should orient them to the expectations, so that this transition is more normal and they get back to a productive life more readily. Right? So in addition to meeting A, they have to meet B, or C, or D, or E, or F. And B is that they've been living in an environment that is characterized by a high risk of initiation or repetition of physical, sexual, or emotional abuse, or they lack social contacts or high risk contacts that jeopardize their recovery, um, and or their social network involves living in an environment that is so highly invested in alcohol or other drug use that their recovery goals are not achievable, um, or they have continued exposure to an environment that makes recovery unlikely. They don't have resources, and they can't really function outside of this 24-hour supportive environment, or they're in danger of victimization. Um, and we don't want to put someone back in that type of environment. So questions we want to ask are, do family members, significant others pose a threat to safety or engaging in treatment? Um, you know, does the individual have friendships, friends who would support their recovery? Do they have resources? Are they able to work? Do they have a vocational history, a work history? Is there some kind of legal mandate that maybe enhances their motivation? Um, and we look at transportation, childcare, housing, employment. All of these need to be considered. But again, I want to remind you that homelessness and court mandates, or someone not wanting to pay rent, are not clinical reasons to support a halfway house admission in and of themselves. We look at the entire picture, right? Um, all right. Any questions about dimensions 5 or 6?
Nothing in the chat, Anita.
All right. So I did put some information in here about continued stay criteria, and this is taken directly from the 3rd edition. I'm not going to dive into that, but I will say it is, I think, on page 27 of the textbook. So, things that you want to consider for continued stay, um, you know, is stabilization. Are the interventions that are being provided working? Um, you know, is the structure no longer required, right? Are they, coming and going to work, finding new friends to hang out with, participating in life again, right? So that's those are all positive things that say, well, maybe they really don't need this amount of structure any longer, right? Um, so when to discharge, when they met their goals, and services that you provide aren't necessary. Maybe they need to be transferred to another level of care. Maybe IOP, partial, outpatient, MAT care. Those may all be more appropriate.
Anita, there is a question that came through. Do you feel a client receiving SSDI would not be appropriate for a halfway house?
Well, I would say, what are they going to do in that halfway house? You know, they cannot just sit there all day and watch TV, right? So what services is the halfway house going to provide for them, um, as an alternative to working and engaging in life? How is that halfway house going to help them engage in some kind of um, fruitful, beneficial life in recovery? That would be my answer to that.
All right, another question. If a
Mhm.
client has been institutionalized throughout his life and has no skills to pay rent or have bank accounts, is this considered meeting criteria?
again, I wouldn't say that specifically, would be criteria, but it could be, a good portion of the criteria. So we would have to look at the whole picture. And I would hope, I know, like, I don't want to call out places, but I know places like Eagleville in their 3.5 and their 3.7 levels of care, they teach those skills. They teach people, how to go on job interviews. They teach them how to write resumes. Those are life skills that I think that before the person hits the halfway house, they could be taught.
Can I ask
And
you?
oh,
Oh, it's on.
go ahead,
Yeah, go
Charles.
ahead, Charles.
It's Rich.
Oh, hi.
I have a. Can you hear me?
Yep.
I have a fairly new client, now even in treatment for 7 weeks. When looking at the 3.1, he absolutely met criteria at all levels of but no dimensions. My one concern is that it is his very first time in treatment. However, he has been using multiple substances on a daily basis for over 50 years. He does not know how to utilize a checkbook. He has zero job skills. He has zero independent living skill. He's meeting criteria. He has received a biomedical condition from his use. And I go on and on all of his emotional stressors in mental three. Um, in my past with managed care, I've had them tell me the curse of homelessness and this being his first time at a 3.5 that they have denied him. And that managed care has used the term the word fail, not me. He has not failed multiple levels of care, therefore he does not meet criteria for being at 3.1.
So, you were breaking up, but I think I got the gist of it. And I don't think that because they never tried or had, I think you used the word failed, which I don't really like that term, but
I didn't
but
it's been used by managed care.
okay. So
That's what I was.
yeah, so I don't think that that in and of itself is criteria that would exclude someone from going to a halfway house. Again, I think we would have to look at the whole picture.
Okay, because sometimes it's, when I write on one admission to for my client to go to a lower level of care with a halfway house, it's often denied.
You're
And it's a
really
step.
breaking up. I can't hear everything that you're saying. Can anyone else hear?
No, it definitely sounds like a little gargled. I'm not sure if someone maybe closer to the computer can.
Hello?
Yeah,
Speaking of, can you hear me?
yes.
Okay, it sounds
But
I'm sorry, I don't want your question to go unanswered. Would you mind dropping it in the chat?
yeah, or if you want to get, I'm assuming this is Leah. If you guys want to get with me later, we can walk through this. But I'm really having a hard time hearing. Sorry about that.
And
All
then there
right.
was one more. Sorry.
Okay. Okay.
If Magellan determines the client does not meet criteria for the 3.1 level of care after a short period of time, can they get the client into the appropriate level of care?
So does that mean if they're in a halfway house and
Yeah,
Magellan doesn't think that they um meet the continued stay criteria to stay
Exactly.
there, can we help get them into somewhere else? So
Yes.
you mean like a lower level of care?
Or wherever they determine they're supposed to be, if they're not supposed to be in halfway house, usually a lower level. Yeah.
All right, so we don't determine an alternative level of care. We just make a determination based on the level of care that you're presenting. Um, if if you come back and say, well, we have decided that for their discharge plan, they need to go to, an IOP. Can you help recommend any IOPs in this vicinity? And we certainly can do that. That is never a problem. You can actually call our member services number, provider services number, and we'd be happy to help you with those. Does that help, Suzanne?
Somewhat, I just want to make a comment or concern. As direct service providers, every minute we spend doing paperwork is a minute we can't spend with clients. I mention this because I have one client that Magellan has demanded ASAMs for every 1 to 2 weeks within his first 45 days in a 90-day program, which creates some pressure on him, obviously, but it feels like he's being left out in the cold if he doesn't meet the criteria for halfway house. What next?
Look, there are a lot of other levels of care. And I would never speak about a particular case that I know nothing about. But what I would say is that generally, if one of our care managers is asking for updates every couple of weeks, then maybe the individual is really not meeting the criteria. That could be the reason. But without knowing more about the case, I would not want to make any kind of, statement for or against that. All right, those are great questions and comments, and we only have about 15 minutes left, so I want to roll through this because I don't think we're going to get to our case studies. So, services provided in a halfway house they should include medical services, and often our halfway houses really rely on community-based services for this. Like they may have a nursing staff, they may not, but a lot of times their medical services aren't provided right there on site. But they should have agreements. Something should be in place with a community medical provider. They should provide pharmacotherapy. Again, they might have an affiliate in the community, and that individual may be have prescribing, medications, either psychotropic meds or MAT meds. They should have case management services. I said this before, it should not be left up to members to make their own phone calls to set up an appointment with a psychiatrist. And I'm going to call out Good Friends. Good Friends is one of our halfway houses that we work with. They're located in Bucks County, and they have a case manager on staff who does an excellent job. They will work with members. They teach them how to make these phone calls. They teach them how to be self-reliant without expecting them to do all this work on their own. Because as some of you have already pointed out, not everyone knows how to do this, they just don't have those skills. And every halfway house should have family involvement, right? And they must, even if the family decides not to be involved, or if the member says, hey, I don't want my family involved, they should at least offer it as a service, and then let the individual and the family decide, and also document that. That's so important. support systems should include, telephone or in-person consultations with a physician, or emergency services. That should be available 24 hours a day, 7 days a week, right? Um, and again, direct affiliations with more intensive levels of care, through referrals, like if someone is maybe becoming, they notice that maybe they're becoming actively psychotic. um you know Halfway House should have something in place and know of some place. Well, we're going to make this referral here because of these symptoms, that this is just not working for this individual any longer. They should have a ability for um lab tests, like have contracts with somebody, ability again to arrange for psych meds, or MATs, and affiliates for less intensive level of care, as people maybe need that service as they leave the halfway house, right? So according to ASAM, and this is actually taken from one of the DDAP technical assistance um, series, that all of these things should be part of the treatment plan. Like, they should focus on activities of daily living, recovery. They should teach things about punctuality and appearance, and help focus on stabilization, and maintaining the stability of SUD symptoms and recovery skills. These are all things that we're looking for from a halfway house. Now, you will notice that a halfway house is only required to provide 5 hours of therapy per week. However, this is going to be a shocker, but in the fourth edition, ASAM requires 9 to 19 hours of therapy in a halfway house. So they really changed that because they're looking for halfway houses to really up their game, and provide services for folks. Um, our expectations are that the halfway house program will um, you know practice with our members, and integrate recovery and coping skills within that supportive environment, um, that that folks will our members will engage in this level of care. I have been around the halfway houses where I've been told someone's in bed. You can't go in there. Well, what are they doing in bed? Well, they've been sleeping till noon every day and we can't wake them up. That's not good care, right? So I would also like to mention at this time what a halfway house is not. It's not a sober house. It is not a boarding house. It is not a group home. In those types of facilities, treatment is not provided. And in a halfway house, treatment must be provided, right? Therapies should include things like evidence-based types of therapy. And the counselors should engage in motivational interviewing skills that help our members. And if someone needs co-occurring care, they should be able to get them the care they need. All right. Any questions, comments so far before we get into case presentation?
Just one. With 3.1 expected to increase services from 5 to 9 to 19 hours, will reimbursements be adjusted or remaining the same? I don't know if that's something that we would have an answer to right now, but figured I'll shoot
Yeah.
it to you anyway, Anita.
Okay. Well, to be clear, we are not moving to the fourth edition. Pennsylvania is staying with the third edition. It is written into law because the state was sued. by DASPOP. And so unfortunately, the legislatures, when they enacted this law about using ASAM, they wrote specifically Edition 3. So, and in order to use Edition 4, that law would have to be changed.
All right. Thanks, Anita. That is all I have right now.
Okay. So let's go on to the first case. So we have a 29-year-old female who's diagnosed with amphetamine use disorder, alcohol use disorder, MDD, and ADHD, who started abusing stimulants in her teens after being prescribed them by her PCP to help in school. This progressed to cocaine use and alcohol in her early 20s. She has used marijuana since her teens to balance out her ups and downs. For the past 4 years, she has been using methamphetamine and drinking 10 ounces of vodka daily. She had 3 other 3.5 admissions, with the last being 2 years ago, and was discharged to a recovery house. She was making efforts to use coping skills she learned on at 3.5, but other members in the house were using, and she was not able to handle the stress of maintaining a job, her negative outlook on life, anxiety, depressed mood, and feelings of hopelessness. She relapsed within a month and stopped attending outpatient after 31 days, stopped psychiatric medications that had been prescribed. Her parents both have addiction issues and are not in her life, and she has a sister who's in recovery but does not associate with her due to her ongoing use. She sought treatment shortly after turning to prostitution to make money and considered this her rock bottom. She was admitted to a pre-contemplation SOC and was justifying her use by stating that drugs should be made legal and that she was using them for self-medicating purposes because it worked better than anything she has been prescribed. She's since developed an understanding that she needs to be in treatment. Though quiet in groups, she has recently begun participating more and has been working on coping skills. Through a family session, she reconnected with her sister, who's not ready to fully engage, but is willing to work with her in family sessions. She's been compliant with Wellbutrin, Strattera, Trazodone, and is seeing benefits from and recognizes that she needs to take the medication. Her motivation comes and goes and requires prompting to continue working on coping skills and insight. With staff help, she is slowly understanding the impact of drugs in her life. And while she continues to ascertain that drugs should be legal, is starting to understand the negative impact on her life. Her perspective on her mental health and substance use is improving, but she is still vulnerable to influence and impulsivity. The facility is requesting initial 3.1 clinically managed low-intensity residential services to provide the structured need to continue progress in treatment. So what we have, these are her diagnoses. This is the requested level of care. Does she meet, in your estimation, the criteria for a 3.1 level of care?
Yes, I think she meets the criteria.
Okay. Do you want to say anything about that, Donna?
I'm sorry, so I'm driving. So
Oh, okay. No worries.
it's okay. I believe because she has a substance use disorder, she's willing to go to treatment. She doesn't seem like she's high risk. She doesn't have any suicidal ideations. And I think so.
Okay. All right. Anybody else?
The chat is a mixed response, some yes, some no, um, pertaining to mental health not being stabilized. Um, unsuccessful while at a recovery house. So we definitely have a mixed response in the chat.
So I would say,
That's something, Anita. What I think the more appropriate placement for her would be the PHP for her to address her mental health and get it stabilized.
that is a good response. Yes, definitely. That could be. Um, and I agree with you. However, she does meet the criteria for a halfway house because she is becoming stable, right? She is seeing a psychiatrist. Um, and if you look at the last three dimensions, she's open to recovery. Um, and she understands her relapse, understands relapse, but she really needs some structure to maintain whatever therapeutic gains she has thus far. But I totally agree with you that a partial hospital, a residential partial hospital, is that what you're talking about? Yeah, um, might be better because actually she would receive more therapy, right, in a partial hospital program than she would in a halfway house. And I know we have had a number of our own members who didn't quite fit the bill for a halfway house, and we had recommended to providers that if you're looking for more care for her, or a halfway or a partial program or a residential partial would probably be more suitable. It's a great recommendation. All right, let's go on to number 2. We have 4 minutes. Case number 2, the member is a 48-year-old male currently residing on a 3.5 level of care. Prior to admission, he had been using 3 to 4 bags of IV fentanyl daily and drinking 6 to 10 beers daily to numb himself and escape reality. He was living with his girlfriend, and the relationship was unhealthy for both. They frequently used together and have been the cause of each other's relapses in the past. He has a strained relationship with his 16-year-old son who lives with his family. Both issues contributed to his social stress and relapses in the recent past. He has been employed as a carpenter, was good at his job, and wishes to return to this line of work. He lost his job due to functional impairment related to his mood and substance use. Since admission, he has been detoxified from both alcohol and opiates and is taking Suboxone. He has agreed to convert this to a long-acting Sublocade injection upon discharge. He has also started on 150 milligrams of Seroquel at night and 20 milligrams of Prozac daily. He has tolerated both meds and continues to indicate a depressed mood and is looking to increase his antidepressant. He has diminishing urges to use and feels the Suboxone has curbed his cravings. Despite his mood symptoms, he has demonstrated self-motivation in his recovery and improved insight into the role his relationship played in his continued use. Despite his son not feeling ready to participate in family meetings, he was hopeful that this may happen in the future. He enjoys and participates in group and is starting to see some benefit from CBT-oriented individual therapy. He has since ended his relationship with his girlfriend and identifies his mental health as a priority for him upon discharge. Since he is not returning to live with his girlfriend, he will be homeless. His family wants to support him, but remain in the periphery of his life until he can demonstrate some stability. They are not offering to support him with housing or financing. He is nervous about the next step as he has mixed success when leaving 3.5 in the past. AA has been positive support for him, as well as his previous employer, who might be willing to give him his job back conditionally if he submits to regular drug and alcohol testing. The facility is requesting 3.1 level of care to support him in his transition because he is homeless and has no access to finances. His diagnosis is opioid use disorder, major depressive disorder, and alcohol use disorder. So, does he meet the criteria to enter into a 3.1?
Because of his employers willing to give him the job back, then he can pay rent at a recovery house.
Yes, you are so right. Yep.
I also agree because he's making his appointments, he's taking his medicine, he's working on his career, and he's doing all the necessary things to um, maintain a 3.1 facility.
Yes. You guys are just rocking this. You're so true. I love you guys. He doesn't meet the criteria for dimension 4 or dimension 5, which he must meet, right? So and he understands his relapse, so he doesn't need the structure. He's gonna have a job, as you said. So yeah, I would say that he's really he is on his way. He is beyond what a halfway house can offer him.
So would he be better off like in a outpatient facility?
Yeah, I would say even IOP for a little bit, so that he can work. Maybe go to IOP at night or during the day, whatever his work schedule is, work around that. Still get a lot of support through the IOP, but work too, which is important to help him live.
Okay.
Any other comments, questions?
In addition, Anita, when you put it in the ASAM, they just can't put that the reason that they want to recommend someone to go to a 3.1 is because he's homeless.
Yes. Yep. That is an excellent point. And I think I may have said that before, that homelessness is not a clinical criteria, right, for a level of care. All right, so these are the halfway houses in our network. I think I got everybody, and if I missed somebody, I apologize. But as you can see, we have halfway houses all around the state. And Pyramid and Gaudenzia, I didn't list all yours out. Gaudenzia has 5 halfway houses. Pyramid has 3. So get to know your halfway houses, get to know their nuances, what they can and can't do. One of the things that we ask is that if you are making a referral to a halfway house, that you don't just make a referral to one, that you at least make a referral to at least 3 different halfway houses, because a lot of halfway houses, their beds are full, right? And there could be an extended waiting time if you're waiting for just one in particular. So shop around.
Anita,
Yes.
I have a question, because we have been told by care managers we must make referral to 5 or more, nothing less than 5 from
Okay.
Magellan care managers.
All right.
Yeah.
So if that's what the care manager told you, then that's what it is.
Okay, thank
Sorry,
you.
Liz. Yep. Sorry, Liz.
That's all right.
So, any other questions, comments?
Yeah, hi.
Hi.
My name's Trixie. I'm a case manager at Bradford Recovery Center. I was just in the chat, and for some reason it's wonky. I can't. I wanted to respond to Hannah Gore, but I couldn't. So in the first example there with the girl that we determined for PHP level of care, after she stabilizes there, this happens all the time. I know in the beginning you said that someone can go to any level of care at any time. So if she goes to a 2.5 level of care and she stabilizes out, would she be able to go to a 3.1? So we encounter this a lot because we have a partial bedded program, a sleepover, whatever you want to call it. And then like they're still, we don't have a work program, so they can't work, they can't earn money while they're here. And then they're still with no income, and they still have no means to get into a recovery house unless we find them a scholarship, which is possible sometimes, not all the time. So I was just wondering how that would go.
Yeah, I mean, if someone meets criteria for a level of care, you don't ASAM, that's the beauty of ASAM. And I have to tell you, I am so old. I cut my teeth in this field on ASAM before PCPC was a thing. And so the beauty of ASAM is that you can enter at a 3.5 level of care. Like some of our folks who maybe come out of jail, right? And they're looking for treatment. They don't necessarily need a 3.5. Maybe they could go to a 3.1. That might be more appropriate, right? That helps them integrate back into the community. 3.5 isn't going to do that, which is one of their basic needs. So if someone is in a partial, yeah, if there's something going on, something changes, you can definitely make a referral to a 3.1.
Okay, thank you.
Yeah, absolutely. I mean, that is really like you can move people where they need to be.
Nice.
That's the purpose of ASAM, really.
Yeah. Thank you so much, Anita.
Yeah. Yeah, no, that's a great question. All right. So we are out of time. We are 6 minutes over. I'm so sorry, guys, but you all had some great questions, great comments. I want to thank you all. If you have further questions and comments, feel free to contact me. I think Arlene is going to be sending out this PowerPoint. And when she sends that out, I'm going to ask her to send my email address as well, so you all have it. Yeah, again, don't hesitate. But thank you all for being here. It's great working with you all.
Thank you.
And then I will just add, I put it in the chat, but I will be sending out the PowerPoint slides and the survey email. If you do not receive it by the end of the week, please feel free to shoot me an email, and I dropped my email address in the chat, but you guys should probably all have it from registration. Okay?
All right.
Thank you all for joining us. Have a great day.
Thank you.
Everyone.
Bye.